Hello, welcome back to my channel. I am happy to see you here once again. If you are just joining us for the first time, this is Simplifying NCLEX, where we talk about everything NCLEX. I bring to you topics that you need to know before your NCLEX examination. If you have not subscribed to my channel, do support me by clicking on the subscribe button and the notification button so you know anytime I upload a video. All right. Thank you for coming back to this channel. Now, today we want to look at a very important topic in NCLEX, which is your traumatic brain injury, TBI. It's like a link lecture from the last one we did. We've actually done intracranial pressure. If not watched that video, you can actually get to my channel and watch that video, because that will be a continuity of knowledge. So for traumatic brain injury, what is traumatic brain injury? Traumatic brain injury has to do with head injury. Okay, so is a head injury that actually has caused a brain injury. So it's like injury to the head, which means injury to the brain. And the severity is determined by a lot of factors, and we can say it can be determined by the velocity and the mass, shape, and let's say the general impact of that object. Okay, so it is the velocity of that object that determines the impact and the severity of damage that is done to the brain. Okay, so we can have a lot of head injuries, which ranges from mechanical to chemical to your thermal to your electrical, but mostly brain injuries occur due to mechanical injuries, which we can actually say are physical injuries to the brain. So when we have physical injury to the head, and when we talk about the head, we talk about the cranium and we talk about the brain. So these are injuries to the brain. And we can classify these mechanical or physical injuries into two. We can say they are injuries from blunt objects and injuries from penetrating objects. And for blunt objects, we believe it can be anything. And for penetrating objects, we can think about things like knives, sharps, and guns. Okay, and here we can have stationary objects, we can have rotational objects, or even moving objects. And how can we say that? What can we associate head injury to? We can associate them to sports. We see people who engage in contact sports having this. We can associate it to falls from height. Okay, and we can associate it again with abuse, where we talk about physical abuse, and we can associate it again with shaking syndrome for babies. Okay, so these are a few of the associates when it comes to brain injury. Now, let's get to business. The basic two types of brain injury we want to look at is the open head injury, and your closed head injury. So when we say open head injury, we are looking at our laceration. So open head injury, we are talking about lacerations. Okay, and then we talk about direct opening to the brain tissue. Maybe let's say direct opening. Under direct opening, we can talk about things like gunshots, which actually opens up the brain tissue. And then we talk about skull fractures. And for laceration, we all know what laceration is. So this laceration can actually be superficial, and direct opening injuries can actually come from penetrating injuries. And we have the skull fractures. And we like to say a general thing about this open head injury. The important thing about the open head injury is that the open head injury is going to predispose your patient to infection. Okay, infection. So this is that patient who is predisposed to what? To infection, okay? That patient is predisposed to infection. And because the patient is predisposed to infection, you are going to watch out for signs of infection in that patient who has an open head injury, because that is a patient who has the microorganisms can actually get directly into the brain, because there is an open wound. It's as simple as that. There is an open wound, and because there is an open wound, you're going to see that this patient can be disposed to infection. Now, I want to talk so much on skull fracture because that's where our NCLEX tip lies. And we have different types of skull fracture. So I'm going to list the types and then we talk about it. Your linear fracture. Your linear fracture is just that simple, clean break, okay, on the cranium. Simple, just like a straight line. And then we have our depressed fracture, just as the name sounds. When the fracture happens on the skull, it actually is depressed. And we have what we call the comminuted. Comminuted is those fractures that comes in fragments, or there is it's shattered, like when you see the pieces of the cranial bone. And then we have the basilar fracture. So the basilar fracture is still unique, very unique, because this basilar fracture is a fracture that happens at the base of the cranium and is very significant in NCLEX, okay? Now, all these fractures can either lead to open head injury or can still be closed head injury. It's good that I tell you that. Let's talk about basilar fracture. Now, basilar fracture, we need to talk about it because it has a lot of significance in the NCLEX examination. So like I said, the basilar fracture occurs at the base of the cranium. And base of the cranium, and there are things that are significant about it that I need to talk about. It is that fracture that occurs at the base of the cranium, and what is that artery that is associated with the base of the cranium that is nearest to that? It's your carotid artery. So when an individual has a basilar fracture, that's the individual who you know at the back of your mind is having a high risk of hemorrhage. So that individual is likely to bleed internally because of the carotid artery. So you can have this fracture piercing the carotid artery and the patient is going to bleed. So this fracture is unique because it is the commonest cause of leakage for cerebrospinal fluid. So it is usually in basilar fracture that you have what we call dural tears. Okay? So the dural tears is just like tearing that portion where we have accumulation of the CSF, where the CSF is supposed to flow. Now there is a fracture that has actually torn it, and you're going to see the CSF leaving its normal location. And because of it, what is going to happen? The signs and symptoms of basilar fracture. Let's talk about that now. So for the signs and symptoms, you're going to have, if you have the dural tear, you're going to be seeing what we call autoria. This autoria is going to be the passage of CSF from the what? From the ears. And then we have what we call the rhinorrhea. And the rhinorrhea is the passage of the CSF from the nose. So that patient who is going to have a clear discharge from the ears and from the nose is usually a victim of what? Of basilar fracture. Okay, so for that patient who has this drainage, how do we really confirm it is CSF? So basically we have two forms of tests we can carry out to show us if that clear fluid is CSF or not. And the first one is our glucose test, which we do with our glucose strip. Okay, just a normal glucose strip, you know. And if it is CSF, it's going to come out what? It's going to come out positive. And we can do this if we have clear fluid that is not stained with blood. What if that fluid that is coming out from the ears and the nose is stained with blood? We're going to do what we call the halo test. And how do we do this halo test? Now, halo test is actually done when we put this clear fluid on a white environment, white sterile background, and usually we use our gauze. And this gauze, when you put this CSF that has been stained with blood on this sterile background, is going to create a ring. So we're going to see a yellow ring formation, and we see the blood getting to the middle, and a yellow ring formation, which shows that the fluid is CSF. Okay, so we've talked about the basilar fraction. We've looked at the basilar fraction. I've told you that it's going to predispose this patient to hemorrhage because of what? The carotid artery that is located there. And we've talked about that the basilar fraction is unique because it is one of the fracture, the head injury fracture, that is going to make this patient to have leakage of CSF from the ears and the nose. Now let's talk about another thing that is peculiar with the basilar fracture, and that's another symptom you're going to see. So we have another symptom which we call the raccoon eyes. Okay, now the raccoon eyes is just you seeing periorbital ecchymosis. So you're going to see, let's say this individual is fair in complexion, you're going to see like a bleeding in the periorbital area. And then we have another symptom or another appearance that makes the basilar fracture unique, which is the battle, we call it the battle sign. Now the battle sign is going to be like that individual who has gone for battle, but that's going to be you seeing at the mastoid area. So you're going to see this individual appear like someone who has been punched. So we have mastoid ecchymosis in your battle sign, and in your raccoon eyes you're going to see periorbital ecchymosis. All right, so that is what you need to know about your basilar fracture, because your basilar fracture is very important. When you see that patient who has leakage of CSF from the ears and the nose or clear fluid, and you've tested it and it's CSF, your mind should tell you that this is that patient who is having basilar fracture. Now, like we had said, that our open head injury is going to predispose the patient to what? It's going to predispose the patient to infection. What happens to your intracranial pressure? In open head injury, this patient, we are not afraid of intracranial pressure. Why? Because there is a way for, if it's a CSF, to leak out. We've talked about the CSF going out. And remember what we said, that it is the build-up of one of the components of the cranium in a way that the cranium, which we know is rigid and cannot expand, becomes pressurized and there is increased pressure. Now, think about it very well. We have an open head injury. If the CSF gets built up, the CSF can escape. So you see this pressure is not increased. If the patient is bleeding, the blood, because it's an open head injury, the blood can actually leave the cranium. So at no time is our ICP a concern for us when it comes to open head injury. The concern we have in open head injury is what? Is our infection, because there's an open wound which can, take infection straight into the brain. All right. So having said that, we are going to be looking at our closed head injury now. In closed head injury, we are just talking about injuries that has occurred in the head, but the head is still closed. So the cranium is still intact. There is no opening. So that's the difference between our open head injury we've done and the closed head injury. So in the closed head injury, we are having an injury to the head, but there is no opening anywhere. Okay. So this is usually still by blunt object, like we said, and is determined by the speed and velocity of this object, which can be by acceleration, which is a moving object to the head. So a moving object to the head, when you have something moving and it comes to the head, that's acceleration. Then deceleration is a moving head to a stationary object. That's the one you see in little children who have learned to walk or run, and they have a moving head going into the tables, into the wall, and what have you. So the severity of this closed head injury depends on the velocity, the force that was applied. And in this closed head injury, it is more dangerous. Why? Are you thinking what I'm thinking? Yes, your intracranial pressure. Intracranial pressure here is increased because whatever that is happening to the brain is within. There is no place for it to escape. Okay, and we are afraid of intracranial pressure. You see, because it has something to do with the intracranial pressure increasing, it is more severe than our open head injury, which I have explained that we are not afraid of increased intracranial pressure in an open head injury. Instead, we are looking at infection as a problem. So let's look at the different types of our closed head injury. We will start with the first Y, which is a concussion. Now, in your concussion, we say it is just a diffuse injury, and in concussion, just remember the word diffuse. Okay, it's a diffuse injury which we don't expect any brain tissue to be damaged. There is usually no tissue damage, and it can range from mild to moderate. And this is the type of injury we see in contact sports like football and other contact sports you can think of. And how will the patient who has concussion present? This patient is going to have transient confusion. So we have a confusion. So when this thing happens to this individual might not be oriented in time and in place, just briefly. This might happen and this might not happen. There might be a loss of consciousness, which will be very temporal. Like we said, the person just hit the head and all of a sudden the person doesn't know where he or she is. So that temporal loss of consciousness might be there or might not be there. And then this patient is going to come with headache. You won't ask why. You know everything is happening in the head. And then there can be repeated concussion. We said it can actually lead to change in behavior or poor concentration. And that's why we actually try to stop children from running their head into walls, because if it becomes repeatedly, we can have a change in behavior and we can have poor concentration on those children. Now, in our nursing role, what is important for us when a patient is having concussion is for us to wake up this patient every 2 hours so we can assess the level of consciousness and alertness, because we are interested in what? Intracranial pressure. We want to use our word GCS, Glasgow Coma chart. If you are still trying to understand what I'm saying at this point, watch my first video, my video on intracranial pressure and my Glasgow Coma chart. Okay, it is self-explanatory at that place. Now, we want to still monitor this patient using the Glasgow Coma chart because we are so worried of increased intracranial pressure. So we want to keep on monitoring this patient, and we want to wake this patient up every 2 hours. So, unless we ask you, you have a patient who has had a closed head injury, and you have come to this patient to actually take a neurological assessment, and the patient is met asleep. That the patient is sleeping. What will be the nurse's action? Remember, your nurse action is to do what? Is to wake that patient and assess the level of consciousness, because that's not the patient you want to sleep off. That patient can sleep off and slip into coma. You are interested in that because it is a closed head injury, and you know that your intracranial pressure is going or might be what? Increased. So that's the patient you want to keep in view when it comes to your Glasgow Coma chart. All right. Now, let's go to the other form or type of a closed head injury, which is our what? Our contusion. Okay? Now, contusion. So, what is happening in contusion? In contusion, there is a bruise to the brain. Just like the way you bruise your skin, maybe when running or doing something and you come in contact with something that has actually bruised your skin. Now the brain is bruised. And this usually happens when an individual have a fall from height, FFH. So if there is a fall from height, you are likely going to get a bruise on the brain, okay? And this bruise on the brain is what we call contusion. Now, contusion can be of two parts or two kinds, which I would like to mention, and that is cue and what we call the counter cue. Now, I will tell you what happens in a way that you will understand it. For the cue, we're actually talking about bruising at the site of injury. So if I had hit my head on the board and I get this bruise just on my frontal lobe where I had actually hit my head, it is cue. But then we have this injury where I have hit my head on the board, and then because the force was so much, I have the brain moving back and front, giving me bruise at the front where I have actually had this injury, and also giving me injury at the opposite direction. So when you run this patient through your CT scan, you're going to see bruising in two directions. So one at the site of injury and the other one at the opposite side. This is a typical example of the injury drivers get when they have a car accident and they hit their head either on the steering and then goes back again to rest. So you have that jarring of the skull, and this individual is going to have bruises at the site of injury and still opposite the site of injury. Now, what are the signs and symptoms of contusion? The signs and symptoms and what presentation are you going to see when you assess that patient? There is going to be alteration in the level of consciousness. Now, this alteration in the level of consciousness can slip into coma because this is a more serious closed head injury, okay? And if care is not taken and the help is not gotten at a time, we can start seeing this patient having the decorticate posture or the decerebrate posture. We covered that in our last class, and I bet you watch that video. Now we have cerebral edema is something we can see here, and in cerebral edema, when there's cerebral edema, what goes to your mind? ICP is already going high. So contusion is a more serious one, and because of that, it comes with some other neurological changes, including your hematoma. Now, hematoma is a big one, which we are going to be looking at in our next video. But I want to let you know that this hematoma is usually seen in contusion. Why? Because it is a bruise to the brain. And you know what happened? When there is bruise, there's inflammation and there is response by the body. And before you know it, there is a cerebral edema and there is hematoma formation. So in the next part 2 of this lecture, we are going to be looking at hematoma, the types of hematoma, and everything you need to know. If you have not subscribed to my channel, please support me by subscribing to my channel so that whenever I upload a new video, you would be the first to know. Thank you.